So welcome, thank you all for being here. I'm super excited to see you. My job with this talk is to set up our next 2 days together. And so I'm going to talk about that process of fitting care. And I'm going to do that by starting out by introducing myself. So this is some of you were at the cocktail hour last night, and you met my husband, Jeff. This is our lovely son with us, Owen. And this is a picture from earlier this year when I graduated finishing my PhD. And I start by showing you this picture because I think it tells a lot about my life. So I have worked through my full-time through both my master's and my PhD, and these two humans have supported that endeavor. That's not to say that we don't have any fun in our family. So this is Owen and I at our first concert, or his first concert. We went to see Taylor Swift, who I love, and if you follow me on social media, you're going to figure that out pretty soon anyway, so we might as well get that out of the way now. I have also been at the Knowledge and Evaluation Research Unit since 2011. So they have supported me in this endeavor of pursuing my education and becoming an independent researcher. And I owe them a lot for that. And along this 7-year journey, I came about a problem in the second semester of my PhD program. And that problem was debilitating pelvic pain. And this went from a problem of, this doesn't feel so good, to I can't stand up, I can't walk, I can't function in this crazy full-time mom, full-time work, full-time school life that I'm trying to live. And as a result of that problem, I was hospitalized. And this was my hospital board. You can see my must get kind and careful care from Victor when him and Claudia came to visit me. So I had sort of been misdiagnosed a couple of times. So at first we were told I had a urinary tract infection. Antibiotic treatment didn't work for that. Then I was diagnosed with pelvic inflammatory disease. Antibiotic treatment didn't work for that, and so the thought was, if we just hospitalize you for 5 days, give you IV antibiotics, you'll be well on your way, off you go out into the world. That didn't work, so I expressed my disbelief that this was actually what was going to happen, but nevertheless said, well, it seems like a reasonable thing to try. And 4 days into my stay, the physician came in and said, I think you were right. I don't think that's what's going on. We really don't know, but you would have improved by now. So we decided that the next step was to have exploratory surgery. And I naively thought that I would go into that and I would wake up and I would be back to normal. I would be out of pain. But I woke up from the surgery in the same pain that I went under in. And I asked my surgeon, did you find anything? And she said no. And so, the day after that surgery, I was discharged out into the world with a long list of medications that I was supposed to manage now on my own for my pain, and a long list of follow-up appointments that I needed to make and pursue and try to find out what my diagnosis was. So that problem led to me needing to access more health care. And this is, I sort of reflected as I was making this talk on the few months that I had to go through this process of trying to access health care to figure out what was wrong with me. And the middle word sticks out the most. So I was being helped navigate this situation with my family, my friends at Care Unit, and some help of my primary care team as well. And as we narrowed in on a diagnosis, we decided that the last consult I needed was a urology consult, because the suspected diagnosis was something called interstitial cystitis, which is a painful, inflammatory, chronic bladder condition. And so it was seemingly, you know, an easy thing to, you know, my primary put in the order for the consult. My mom wheeled me out in the wheelchair to the appointment desk because I had debilitating pelvic pain and was now recovering from surgery on top of that. And we handed the order slip over to the appointment desk, and the appointment desk calls the other appointment desk in urology, and she sort of has this puzzled look on her face. She's asking some clarifying questions, and she hangs up the phone. And when she hangs up the phone, she looks at my mother and I and says, "I'm sorry. Your appointment, your referral was denied. We don't see patients who have a suspected diagnosis of interstitial cystitis." And then I cried, because what else do you do? This was not a matter of, oh, we don't see that, but here's, you know, your next steps, here's who you should go to. It was up to us to figure that all out. So luckily, I could lean on my social network, many of who were made up of health professionals and other clinicians who were able to get me to the care that I needed. So there was a urogynecologist in our social network, and he agreed that he would treat me with the condition that he was not an IC expert, and if my condition, you know, sort of proved more difficult than standard treatment, he would need to refer me up to the Twin Cities and Minneapolis. I said, great, like, at least I have a path forward, that will be fine. And then he told me something that really shocked me. He said, "I will never put on your problem list a diagnosis of interstitial cystitis." And that is because forevermore, when you seek care here or anywhere else, you will likely be discriminated against as a patient. You will have a harder time getting the care that you need. So to this day, if you look at my medical record, this is what it says. This is my official diagnosis, and my primary care doctor was floored by this. And so he wrote a very snarky note in my chart when he learned this, and he said, "She has not been able to have a urology appointment, as patients with a diagnosis of interstitial cystitis apparently are not evaluated by our urologist." So I began the process now of understanding a condition, again without much support from the healthcare system proper. And so I wish I could tell you that happened through a process of, you know, great shared decision-making and great care, but really what it took was me as a researcher PubMeding everything. And so looking through sources of what it meant to have this diagnosis, what were some of the triggers, what were the latest guidelines in how to care for this, other ways to manage it, off-label drug use, all of this I was trying to figure out and navigate mostly on my own with a few periodic consults with this clinician. I also found very helpful patient-to-patient networks. So many conditions have, you know, triggers that are not necessarily known. And so anytime I was eating a food that I thought might cause a flare, I would look it up on these patient-to-patient networks to try to understand, you know, what was happening. Then we needed to select care for me, and again, I wish I could tell you that shared decision-making played a part, but really it was just a whole bunch of trial and error, in part because there's not very good evidence to support a shared decision-making process in this condition, as well as the fact that there just wasn't, you know, support in terms of decision-making. And then we needed to tailor my treatment. And I had a good clinician who was actually very cognizant of these ideas of treatment burden. And his idea of treatment burden was a lot of pills. Like, oh my gosh, we just, you know, have you on, you know, these 18 meds, and how are you going to survive on that? And then we had a really enlightening conversation about what treatment burden meant to me. Treatment burden meant to me that I could eat what I wanted, I could travel where I wanted and not have to worry about this very restrictive diet. And I could have my cup of tea in the morning because I'm not sure about y'all, but I need my caffeine, particularly to live the life that I live. Then there began the process of integrating this into my life. So the work of being a patient is something who you have done the distance course have learned about this, but the work of being a patient involves making sense of it. It involves all of that reading the pamphlets, trying to understand how this fits in your life. You need to organize the work, and you need to enroll others to help you. And that might not sound so hard, except you don't look sick. And so you're not necessarily someone who immediately, people are going to offer help to you. You have to do the work of asking for that. Then you need to do the work. So you need to set up those pill boxes. You have to take the pills every day, and you have to keep going. And then you have to reflect and monitor and appraise, is this actually worth it? For me, I have a pain feedback loop. So if I don't adhere, my body tells me very quickly that I'm not adhering and things are not going well. But for many chronic conditions, you don't have that. So a lot of this appraisal and processing actually needs to happen in your head rather than your body immediately telling you that this is the problem. And that assessing of whether your care fits and is working might not seem so difficult, except current research is showing that at least 40% of patients are saying that their treatment burden is now unacceptable. And in that study, and also the work we're doing for patients with kidney disease, we're seeing that those of us who are younger, who are managing family, aging parents, work, all of that on top of illness itself, report worse treatment burden. And finally, the process of fitting care also means we take stock and then we revise this care. And that requires capacity to do, to continually go back and access that care and get back in that loop and figure out, is this working? How are we going to move forward? And right before I was actually diagnosed, I had done this work to develop a descriptive study or a descriptive theory of patient capacity. And patient capacity, we often think about it as simply resources, but what we found is that it's so much more. So as a patient, your biography, as a person, your biography matters. So who you are and what you do in the world and where you find passion is important. And chronic illness comes along and it interrupts all of that. And when it does, some patients do a great job of integrating that back into their biography and moving forward with their life, much like I'm doing with giving you this talk. But for many patients, they get stuck in that reframing. They're actually sort of at war with this diagnosis, with the treatments, with everything that they need to do, and therefore their self-care suffers down the line. Resources do matter. So things like transportation, educational resources, financial resources, all of that matters. The environment matters, both home and neighborhood, but also the healthcare environment. So our patients met with an environment that says, yes, we're going to find a path forward. Yes, we're going to integrate care into your life. Or are you met with a healthcare environment that leaves you sitting at the waiting desk crying? That impacts your capacity for care down the line. The work of being a patient, ironically, actually can generate capacity. And that sounds a little strange, but think about if you've ever been given a test that's overwhelming. And the professor says, oh, it's all in the book. And you're thinking, this test is tomorrow. How am I ever going to figure all of this out? Well, the experience of receiving a discharge summary isn't all too different for a patient. And so if instead we break down that work into these bite-sized pieces that people can take on, they move forward. They have more capacity. And finally, your social network matters. Do you have one, and are they supportive? And I think you can see how my social network played a part in actually getting the care that I needed and moving forward with my life. And this workload to capacity balance is so important because it actually affects patients' abilities to continue to access and use healthcare and enact their self-care, and in turn affects their outcomes. The problem is, in healthcare, we typically only look at the outcomes piece. We don't take consideration of patients' workload and their capacity and how this is all working out, and therefore, we see an outcome worsening, we throw more healthcare at the problem, only making the burden of treatment worse, while the patient's capacity continues to decrease. And you can see how this turns into a somewhat vicious cycle. And hopefully, if this process of fitting care goes right, which luckily for me, I was able to navigate through it, we go back into the community and hopefully have a solution that fits our lives. And when I went through this process, I came back to work and I faced an interesting dilemma. So I had been developing this program of research on chronic illness for 5 years prior to, having all of this happen. And I faced the dilemma of, do I continue that path of research, ignoring all the things I just saw in the trenches, or do I let that influence where my research is going? And so, as the fire in my bladder subsided, the fire in my heart knew that I had to let it influence me. And not because talking about my bladder is particularly exciting with strangers, but because I realized that I was simply a single data point on this wave of chronic illness that's growing. I also realized there's a whole lot of other people that make up that wave and data point. And as I began to share my story, other people started trusting me with their stories. And many of them trusted me to add them to my presentation. So my friend here, who's a wellness coach, a health educator, can tell you all the things you need to do to be healthy and does them all. And yet she can't stand up some days because of debilitating nausea and dizziness. And they can't figure out what's wrong. And she's in this loop right now. She's in this process of trying to fit care, oftentimes without the help that she needs. People who showed me what it looks like to integrate your child's treatment regimen into vacations, or what that heavy burden looks like for a kid with a Lego piece. People like this who reached out to me through Instagram because I had shared a story of my IC, and she had almost lost hope because she didn't have anybody by her side helping her navigate. And through conversations and messages, we started helping her navigate the healthcare system, pharmacologic treatments, non-pharmacologic treatments, and now she's having pain-free days. She has hope again. Patients who showed me the difference 12 hours makes for people living with chronic illness. What you see is the afternoon side of us, but the reality is 12 hours prior, this person was wearing a hospital gown. Friends who've shared their joys with me, but behind those joys set these medications that keep us going. They're behind closed doors, on tables, in homes. And sometimes it's not the medications that get us through, it's things like our cats and our Snapchat filters on infusion days. And what I want to illustrate to you in the second part here is that this process is something every step of the way the care unit is working to improve. And I show you mostly things here that are not done. And the reason for that is because This work is too big and too large to do ourselves, and I hope that you find something that excites you that maybe you take on as well. So the problem of accessing care, this was deeply influenced by my experience. This was not an area of research that we were doing. And now we're actually looking into what is that patient experience of living with what we now call undercared for chronic suffering. Living with conditions and symptoms that are not easily diagnosed, treated, imaged, measured by typical healthcare standards. And Dr. Christina Lavecchia in the crowd is helping us lead on that front. In the process of understanding care, Dr. Ian Hargraves here is setting us forth in what it might look like to understand what care means in conversation, not in the background PubMeding by yourself. So, what is the problem that we're dealing with? What might we do about that problem? What options do we have? Can we try those on and see what they look like in life? And finally, picking a path that makes sense to move forward. And also having the ability and the openness to know that the first time we do this, it's probably not going to be right, and we can go back and support each other through this process again. In selecting care, our team has developed countless decision aids that are focused on treatment decisions that commonly come up and helping patients and clinicians work together to choose through shared decision making what makes sense to them based on the issues that matter to them. In tailoring care, we've developed discussion aids that start the conversation. This is the ICANN discussion aid, and it talks about what's going on in your life, what's going on in your health care, and are those things working together or are they not? So letting those things drive the beginning of the conversation instead of waiting for them to come up or maybe not addressing them at all. Also on the tailoring care front, we realize that cost has a really important influence on what patients choose for treatment, what's in their ability to pay. And Dr. Juan Pablo Brito, who's also here, is leading us on this front in developing shared decision-making for cost conversations as well. In integrating treatments into patients' lives, we've developed an intervention called capacity coaching. And this is where a patient and a coach work together one-on-one to take a look and pick apart those things in your life and things in your health care that are causing you to be stuck and helping you navigate and increase your capacity through coaching and through the principles of minimally disruptive medicine, increase your capacity for self-care. In assessing what treatment burden looks like, we are doing research. This is actually data from 11,000 Mayo patients on what are the issues of treatment burden that matter to you. So this was given with patient satisfaction surveys. And what I want to point out that might be surprising to people, even in Mayo patients, so orange is no problem, so where you see more colors is problems, people have trouble paying out of pocket for healthcare. That's their #1 treatment burden. Next is adhering to the exercise and the diet that are recommended by my doctor. And the diet and the exercise piece we've actually seen in our videographic studies. When we use the ICANN discussion aid, those are the two issues that come up far more frequently when we use the aid than when we don't. Revising care. So, in addition to that capacity coach working one-on-one with you, when integrated into the primary care team, that capacity coach also serves to quarterback the team in the sense that they're able to say, this is where the patient is struggling, this is where their treatment burden is high, this is where we're working on building their capacity, and therefore perhaps we should think about tailoring care in these ways. And we tested this at the VA medical centers in Milwaukee and Chicago. And when patients move back into the community, we don't stop at the healthcare center's doors. Dr. Erin Lapine is leading us in developing a well care system through the program called Well Connect, which you can learn about here as well. And Well Connect supports patients living with chronic disease through programs like the Chronic Disease Self-Management Program and disease prevention programs like diabetes prevention, fall prevention, etc. So even out in the community, we're doing work. So what I hope that you can see through both my patient story and what we're working on right now is that right now healthcare looks a lot like this. It's a messy Tetris game where we throw the pieces onto the board wherever and we hope patients make sense of it, but most likely they're actually just going to run out of capacity and lose the game very quickly. But in working on healthcare that fits, we can instead place the healthcare pieces carefully for patients in such a way that all of that at the top is leftover capacity for them to pursue their life's hopes and dreams. So I want to go over the program with you a little bit so you can see where some of these things will begin to come up throughout the conference. You have this in your folders as well, and the folders have room numbers on it. So we're here at the beginning. After this, we'll move to a large group breakout session where we will talk about using some of these tools, like the ICANN discussion aid. We'll work on using that. We'll use one of the decision aids as well, and sort of have a crash course learning on what we have been experiencing in the last 5+ years. We'll then move to another large group breakout, which we will have a patient case from our dialysis work that we will try to apply some of these things that we're learning as we go. Then we'll have lunch. Lunch is provided. During that time, some of you will be giving pitches, so you've developed them through doing the distance course, and now you'll be giving those, receiving feedback from the crowd, and hopefully also sparking ideas for collaborations. Then after lunch, you have your choices of small group breakouts, which you're signing up for. If you haven't done that, that would be something you would check with Kirsten on. Those breakouts, you have design, which is led by Ian and Maggie and Kevin. And that talks about sort of our process that we use for design to develop these interventions and think about problems in the healthcare space and how we might move forward through them. We have a small group breakout on mixed methods evaluation, so if you're interested in sort of the research side of this, oftentimes we need mixed methods to answer our questions, and so that's a good breakout to learn about that. That's with myself, Carl May, and Sarah Dick, who is a study coordinator who used to work with us. Then we have the SDM in practice, which will be moderated by Victor. We'll have clinicians who are actually using some of these shared decision-making tools and strategies in practice. So they'll each talk a little bit about their experience, and then it'll be an open dialogue after that. And then the fourth breakout we have is with Erin Lapine about that Well Connect system. Then we have a coffee break, caffeination required, and then we will move to Summer Allen, one of our physician champions. We'll be talking about fitting care using the patient voice, which she has been working on in her practice, in her research, and can give you kind of a good clinician perspective on that as well. As we mentioned at the networking hour last night, if you were not there, we are doing something kind of weird. We are hosting a open networking opportunity where we have actually invited the community to come to the Chocolate Twist and interact with you guys, because oftentimes we host these conferences and we keep them behind closed doors, and the community never has a chance to interact with the researchers that are at the front line and that impacts them considerably. We hope that you will join us for that, and we can learn from them as well. And then finally, tonight there's a social. It's a dinner at 300 First. If you haven't signed up and you want to sign up for that, Kirsten is the person you want to talk to. Day 2, we will open with a plenary from Dr. Carl May, who we're extremely excited to have here from the UK. And Erica Linander and I from Yale will be doing 2 large group breakouts in the morning on culture change. Because as you realize, probably seeing some of this, you think, wow, the culture of my organization is not necessarily in alignment, and we're going to talk about some of the work that they've been doing to shift culture in alignment with some of these more patient-centered ideas. Pitches the same for lunch tomorrow, same breakout layout in the afternoon, and then Dr. Ian Hargraves will close the conference tomorrow afternoon. So these are the 3 words I thought about a lot as I was putting together the curriculum for this year. And so I hope that you, at the end of these 2 days, are left with ways in which you might innovate, ways in which you might implement, and I hope that you leave here with some inspiration to carry you on the road ahead. So I'll close with a quote from Miss Rachel Hollis, who I love. She says, "Nobody, not a voice of authority, not your mama, not the foremost expert in your arena, gets to tell you how big your dreams can be. They can talk all they want, but you get to decide if you're willing to listen." And friends, I dream of a healthcare that is so different from what we see now. A healthcare that is so different from the one that left me sitting at that appointment desk. And I hope you join me on that journey.
So we have some time for questions for Casey. There's a question.
Come on, turn the lights up. I don't break it. Lights. What are we at now? Okay, let's see. Low, medium. Medium? How's medium? Good. Okay.
Any questions or comments? I have one that people think and reflect on. You've given them quite a lot. Is you mentioned at some point that you thought the evidence was not there to support shared decision making. Yet at the same time, it looks like that gynecologist and you were able to make some good decisions together. Can you help us understand that apparent discrepancy?
Yeah. So I think what I meant by that is oftentimes when we build decision aids, part of what we take into consideration is what does the evidence say. So for example, what does the evidence say about how often this is going to work, or how much this is going to reduce your risk, or maybe all of these choices have the same effect, but they differ on these areas that matter to you. And in reviewing the evidence, trying to make sense of my condition and what could treat it, there just was not a lot of that information. So there's not a lot of pharmacologic medications for it. And the ones that there are, it's, very, very small trials. So these are, maybe 100 patients. And a lot of the stuff they talk about, when you read the literature, is, it's kind of a 50-50 shot. Like, it might work, it might not. And so it was much more a process of thinking through what this meant in my life. Rather than having a robust body of evidence that could tell you, for example, what were the long-term side effects, how likely was this to work, what was going to matter in my life versus what these drugs would do. So that's kind of the what I meant by that, is it didn't have the robust body of evidence that we normally are able to lean on when we create a lot of our decision aids.
Question.
I really liked your talk. It gives food for thought. I need to state that first because I have a question for you. Having practiced for over 35 years, I am the first one to acknowledge that many of the things you've touched upon are not in my area of expertise. As a matter of fact, being a cardiologist, my expertise is being sucked into more and more knowing about my fields in cardiology. So who will be having this role, this important role, to actually provide this for the patient that you've just described? One. Two, you noticed that one of the most important features for patients was the cost of care. If we add more elements into the cost of care for the patient, how are we going to allay that fear that patients are having? Are we just adding this onto existing caregivers as part of their duty? Or do you see a way how this is going to be absorbed by the system? Or
Sure.
how do you see that?
So, great questions. I definitely don't have all the answers, noting that much of this work is still in progress. What I would say is, I think if, for example, we talk about, who is the person? And I think that's probably different in every setting. When I talked about, for example, capacity coaching, so that person who works one-on-one with the patient to try to help navigate some of these issues, build their capacity, etc. In our pilots at the VA, what we actually found was that the best person was a peer patient. So this was actually a peer support specialist, which the VA now hires. There are lots of them. And they already sort of existed in both the behavioral health and the primary care spaces at the VA. And so we simply just helped train them in what this model would look like and did a couple-day training with the primary care team. And that was how we integrated them into the team. And that didn't actually require any additional FTE because it was already a person that they had. So we really want to always build on existing things that are working well rather than just trying to add additional costs, which I think you mentioned. And I think in regards to your other question about cost, I think a lot of this, simply opening the doors to patients and not having them figure this out all on their own, I don't necessarily think that's going to add cost. There's an opportunity cost of people just trying to navigate through this by themselves.
Casey, don't get me wrong. I fully support that. The problem that I'm seeing is the cost is not necessarily accounted for in the right places. Because you mentioned in passing that the VA, and I know of the system, has peer patients that they're hiring. So there is already a cost there that's being given. I am all for this, so I don't want to, paint this into the corner, but I am very concerned about you're requiring a very flexible system. Just as you said, every patient is an individual. Where does the patient need help? Capacity coach, who is that? Who's going to create that? And yet, I'm often wondering if we are efficient so the patient has more work capacity now, more reintegration capacity. That's not something that's being credited towards the healthcare system, but that's where the cost is. Have you given some thought about the integration of this effort among all of community members, or constituents, so to speak?
So I think I think what we are doing is we are piloting in different spaces. So I would not say that there is any one, we've never made the whole thing work everywhere. We have worked with systems to figure out what of these principles they can bring in and help them think through how that works. So I think that, I don't think we've necessarily done be-all, end-all, and Aaron has a...
Yeah, I think we'll hit on some of those issues in the Community Well Connect Breakout, and talk a little bit about some of the currently available public health funded resources we can just access to fulfill the same end for those sort of pragmatic reasons. I think that might address some of those questions.
I'm going to let Maggie also has a comment on that same point.
Yeah, so I think kind of relating to the things that you were bringing up is part of the reason why we started the Patient Revolution program, which is kind of the companion program to the care unit, but it's focused more on putting kind of tools and resources in the hands of patients and caregivers and communities as potentially a way to start to drive some of these conversations. I think our fundamental hypothesis here is you're absolutely right, to really change healthcare in the big ways that we're talking about requires policy change and change at the systems level, which is not something that any one clinician or small group of clinicians or even small group of patients can necessarily do. But we also have realized in the work we've been doing for the last 15 years that if we're waiting for the people at the top of the food chain to decide that they're going to change it for good reasons, it's just not going to happen. And so what could we be doing and how could we potentially be acting in the world that might begin to draw attention and awareness to some of these issues and hopefully begin to catalyze people to come together and start to agitate for some of these larger things, in particular patients and clinicians. And so I think if you think about cost, one of the things that we're kind of starting with is the idea of what if we just say it's okay to talk about cost in the doctor's office? It's okay as a patient to say, I'm really worried about how much this costs. I can't, if this costs more than this, I can't afford this. And for clinicians to be able to respond and hear that and even though they may not be able to solve it necessarily, but actually once they know that cost is something that's important to their patient, they may then be able to get creative, or they may be able to point to the types of programs that they now know about that are in their community that might be able to help this patient. It may help solve and create a bond and a connection in that one small moment. It doesn't solve the problem at a systems level, but who knows what might kind of emerge from that awakening on the part of that clinician, that understanding on the part of the patient, who then may turn to Instagram and other online things and begin to kind of draw together. So I think we see it as what are the small things that we could potentially be helping people do today that might lead up to the millions of steps it'll take to actually change the system.
Carl?
I think we're touching on the problem of scale almost here, aren't we? So the question that I want to ask Casey, and don't feel obliged to answer this personally, but I'm quite interested in the idea of a minimally disruptive intervention, because it's quite clear to me that trying to change big things is very hard in large, obdurate organisations like hospitals. What was the smallest thing that your physician could have done that would have made your life better in the journey that you've described?
Yeah, I think there's two answers. I think the first was simply opening the door.
Yeah.
Because if I wouldn't have had that person say, yes, I will take care of you, I don't know how I could have gone forward. In that moment, I think once that care was established, I think understanding exactly what matters to you. What is that biography? What is your life like? And what do you want it to be like? That question, I think, is huge. And actually, in ICANN, we have the question of where do you find joy? Where do you find the most joy?
Yeah.
Because I think that anchors that anchored almost everything after that.
Okay, I hear that, but surely the really important thing that physician could have done was acknowledge the reality of your condition. You know, you have a whole system there that's saying, no, we're not dealing with this. We don't
Bye.
Yeah, off you go. And I think back to about 25 years ago, I did a load of work about medically unexplained symptoms of chronic pain. And what you're describing is something very similar to the way in which these sorts of problems were constructed in English primary care in the 1990s. There's a kind of historical continuity to some of this stuff, which is about the whole profession saying, we don't want to deal with this. You need to take that somewhere else, perhaps to a shaman or somebody
super evidence-based,
mushroom over your head, or feathers or whatever. But we can't deal with this, and it seems to me that that's at the centre of your account, of your personal account, is the refusal of the system to acknowledge that you had something wrong with you that had a particular name.
Yeah, and I think that that's much about what the work that Christina is now leading with us is, in having that experience. Of course, right after I got back, I started digging, I can't be the only person who experienced this, and no, the answer is no, I was not the only person that experienced this, and it's not just my condition, it's many, many others that are either medically unexplained, or for that matter, that can't be measured in a traditional physiologic way that's very nice for our dashboards in the healthcare system. And so I think there's a lot more to come in that space of what does it look like to bring kind and careful care to those situations.
Juan Pablo, can you have...
Yeah, so what fantastic presentation. What do you think the clinicians do not want to see?
She's tough.
I know, I'm such a difficult patient, that's why. No, I think honestly, I think part of it is that it's not a condition anybody's going to make money from. But there...
You could change that.
Yeah. Well, there is at least one pharmaceutical company that's making money off of it. I know that. But I think it's a tough condition to treat. So there are stepwise guidelines for it, but those don't always work. And it takes a lot of time because it's not something that you can throw a pill at either, because you can take meds, and most people need to, but you also need to manage things like stress and diet and exercise, and that whole picture takes a long time to put together.
Yes, and the reason I'm asking is that sometimes I don't want to see specific patients as well, and I have to acknowledge that. And one of the reasons is that the culture where I live, we like to fix.
Mm-hmm.
We are fixers. The moment that we cannot fix, then when we feel uncomfortable. So all the process that you or we are developing is actually a different culture, that we are not fixing anything. We are just companions on this process of life. When you get sick, when you are in trouble. So this requires a significant shift in the culture of how we see care, from fixing to something else. And I think I think in your case, as in many other cases, we don't have the tools to respond to something that we cannot fix.
There are days in which we wake up and think we're doing archaeology and rediscovering general practice and primary care, right? Where people join people in the disease process without intent to fix, but and somehow we seem to have forgotten. Erica?
Thanks, Casey, and I'm really struck by the power of your personal narrative to kind of bring this conversation to a different place this morning. Very pleased, so thanks for that. One thing that kind of jumped out at me is, so from sort of qualitative researcher perspective, your pictures are powerful, right? You've got these pictures of people that are managing these conditions, and you showed that you know, the mom that had the bags taped up across the mirror and the little Lego guy. And a lot of that, to me, that story was about the management of that before you can even get on with what people would call your, like, real life, your day job or whatever, right? And yet, that heat map that you had pointed right at the financial barriers. And so I wonder if you can kind of comment and reflect on what, to me, felt a little bit like a disconnect, like that voice of the softer barriers, if you will, to me didn't quite jump out in the heat map. Is that because patients don't, as they're responding to a survey, don't feel like that's the right answer, or they can't talk about that? Like, what, you know what I mean? Can we bump those two data sets up together?
And I have 30 seconds. So you're saying that in terms of the financial barriers stood out, like that was a big deal versus...
Can you go back to the slide?
Yeah, absolutely. In my 30 seconds, I can go back.
Yeah.
This one.
That one, yeah. So that like survey data says,
Yeah.
oh, well, the biggest barriers are the financial ones,
Yeah.
right? But your pictorial data said actually the barriers are, I got to carry my bags with me when I go to the hotel, and I got to make sure that if I'm traveling, I don't leave them at home, like all that stuff. Or I might wake up not able to do the stuff I plan to do today because I have this debilitating pain. Or
Yeah.
so there seems to be a disjoint there.
I think I think that there's a whole, talk to JP about this too, because there's a whole body of work that we're developing on how people, yes, this is a huge problem, but it's also part of that behind the scenes navigation. So there are people who are figuring out, can they go to a different state or a different country? Can they, can they share, I buy strips for my diabetes and you buy the, meter, or, so there's all of this back end work that maybe was not depicted in those pictures, but it doesn't, that's also because it's silent in a lot of ways, because you can take pictures of the medications, but you can't take pictures necessarily always of all the things that you had to do to get those medications. So I think that's just the...
So there's going to be, I'm glad there's a lot of hands, that we have a little bit of a walk to the next room where we're going to have the breakout session, which is in the 2 floors down. Please, before you move, please join me in thanking Casey for a wonderful work.